So Omid, back to you. There was a very interesting report, I believe it was actually an FDA report from a number of investigators at the FDA, where they have the capacity to take data from multiple large randomized studies, and they essentially have a meta-analysis, which wouldn't be possible any other way. You or I or a pharmaceutical company would not have access to other companies' data, but the FDA does. And with permission, they can do a meta-analysis on, for example, there was an article just recently in Lancet Oncology where they looked at what happens when you continue PD-1 blockade beyond RECIST progression. So is that something you would routinely do? Do you think the data would change practice?
Well, there's been some data reported that there are responses after RECIST progression. And now that's not a significant proportion. It's about 4% of all comers. But it is something that I would do, that I may do if there aren't other options, or if it's a first look. Again, with PD-1 therapy, I don't expect to see the late responses of the magnitude that we've seen with anti-CTLA-4 therapy, but yes, I would take someone. We've seen in the metastatic setting that patients who respond or have stable disease after multiple dosings can get to a partial response and a complete response. So it depends on how that patient has progressed, what options are available, and how early the look is. If there's progression on 2 imaging time points, then I would switch and look for something else. I think it's important to bring that forward because I have seen patients who have been referred who have continued on, who are slow progressors, right. And we have options that have survival advantage. I've also seen patients who've been taken off too early.
And do you mind if I ask a question? From my medical oncology colleagues then, so how do you decide this? When is that progression? And they sort of, is it that 12 weeks, 24 weeks, 36 weeks? Or
well, here's a good way to go around the table. So Michael, how do you decide who you're going to treat beyond RECIST progression? What qualities? Are there 3 additional R's that you look for?
Not yet. Maybe at the next video we'll have 3 R's for this topic too. But one group I would think about would be patients who have some degree of benefit, yet technically would have been RECIST progression. So if you have some lesions at baseline that are starting to shrink, but maybe there's a new little lesion, I would continue that patient because there seems like there's something that's going on that might be beneficial. A lot of the patients for whom we say that they responded after progression progressed with a new lesion, but their index lesions were still shrinking from baseline.
Well, I have 3 proposed R's. You want to see a patient who had some regression, not 0 regression. You want to see a patient with a mixed response, perhaps, and then you want to see a patient with regularization of labs and without significant toxicity. So there's your 3 R's. I love it.
Yeah, and I wanted to comment.
Jason?
That's really what I was going to get, and I guess I'm not alphabetically inclined or something. So, but for me, it's just what's going on with the patient, right? So I mean, my patients love this. I mean, they think I'm BSing them or something. But when I go in the room, I say, "How are you doing?" And they always think it's just like an icebreaker. But in fact, I am asking them, how are you doing? Because that really can make the big difference, right? So if the patient, especially we talk about patients who are getting diagnosed earlier, they have less disease seemingly now than they used to. A lot of these people are well. So are they still well? And if they're still well, then I'm willing to kind of continue a little bit longer, but not too long. Because the other thing that we see is people do get this dragged out way too long, right?
But I think if you came in and you said, how are you doing? And they say, I'm all right, I'm remarkably better, might be another R, that you can feel comforted in going there. Obviously, we do have options on progression, but even with the best options, those response rates are low, and you would hate to throw that away or introduce more toxicity.
You think about one other R is that we have to be a little careful about too much reassurance, because in patients who are clearly, progressing, I think there's a real sense that's out there and a lot of hope, obviously, about. I have heard immune therapy takes a long time to respond, and maybe I'm going to be fine with just staying on this. But unfortunately, most of the patients that have every lesion growing or new things growing after several months at least of PD-1, unfortunately, will continue to progress. So I think we have to be careful about too much reassurance, and we need to be thinking in our heads, what is my backup plan? Even if you keep going for a little bit of more time, I think you have to be ready about what am I going to do if we need to switch, because most people will probably need to switch at some point.